So first of all, we will talk about its epidemiology. It is most common malignancy affecting men in United States. Typically seen in male older than 50 years of age. So age is the major risk factor here. Incidence increases as they get older than 50 years of age. 20% increase in incidence at the age of 50, and there is 70% between the age of 70 to 80 years. It is commonly seen in Africans. Obesity is a risk factor for prostate cancer. As you can see, the cases starts to see from 45 to 50 years of age. Then it increases as age increases. So age is a major risk factor for the prostate cancer. Then we will talk about the clinical symptoms. It includes so the localized prostate cancer is asymptomatic. There's no any symptom in localized prostate cancer, and the symptoms commonly seen as dysuria, the painful urination. Then there is hematuria, blood in semen, also difficulty in starting or stopping the urinary stream, discomfort when sitting, discomfort or pain when sitting caused by enlarged prostate. And there is also can be seen new or sudden erectile dysfunction. Bone pain is also associated. Nocturia is also seen. So these are the clinical symptoms of the prostate cancer. Then diagnosis. So diagnosis of prostate cancer requires detailed physical and clinical evaluation. Physical and clinical evaluations, which will include blood test, imaging. This is digital rectal examination, biopsy, and prostate specific antigen tests. Before going to those, we will take a look about its classification, staging, and histology. So classification. There are mainly four types of cancer, prostate cancer. First of them is acinar adenocarcinoma. Acinar adenocarcinoma refers to the cancer which arises from the mutated semen secreting glandular cells. The glandular cells which are secreting semen, the origin from those cells is known as acinar adenocarcinoma. This is the major one. And when we say prostate cancer, we are referring to this carcinoma, acinar adenocarcinoma type. Then there is ductal adenocarcinoma. When there is the tumor cells are originated from the duct of the prostate, the cells that lines the duct of the prostate. Then another one is small cell prostate cancer. The in this case, tumor cell originates from the flat cells that covers the gland. And there's another known as squamous cell carcinoma. This is not particularly the cancer type of prostate cancer, but it's originated from prostatic urethra. So the cell's origin is from prostatic urethra, but moves very commonly inside prostate. So it's also uh, called a type of prostate cancer. It's also known as transitional or urothelial cancer. So this is the classification. We can see here, this is the adenocarcinoma. This part here we can see, this is the normal cellular glandular structure, but here we can see this peripheral zone where no there is white solid of cancer, as contrast to this. These are a spongy part, and here we can see some solid part. Then this is the gross appearance of the adenocarcinoma. Here we can see this multifocal cancer sites. Then we will move to the histological features of malignant prostate gland. These are the characteristics we can see on the histological slides of the prostate cancer. So these are loss of convulsions, papillary foldings. What this means is, in normal glandular structure there are papillary foldings like this in prostate gland, but in cancer stage there is loss of these papillary foldings, and this becomes globular. So there is loss of papillary folding or convulsions and single layer cell. In normal we can see there are double layer of cell. in normal, but in cancer stage there is only single layer of cell making the gland, and multiple gland crowded together. So we can see like this. Later we will see in histological images that there are back to back appearances. So this is one gland, this is another, this is another. So there are multiple glanded crowded together, and stroma becomes less, little stroma, as the most of the space is taken by new malignant cells. So stroma becomes lesser, and we can see more and more glands crowded together. Then there is prominent and purplish nuclei. Now we'll move to the histological slides. So here we can see this is the normal spongy, and this we can see crowded. This is all smaller glands. So this is very crowded glands. In next image, here we will see this is very prominent and purplish nuclei. These are very prominent and purplish nuclei seen in, and this is the hallmark of prostatic adenocarcinoma. Large, prominent and purplish nuclei. In this image, we can see gland, very less space in between. So there is loss of stroma, and all the stromal space is occupied by newly formed gland cells. So there is gland upon gland, very crowded glands. And here we can see there is no glands, no particular gland formation. So there's loss of glandular tissue, glandular appearance in this slide. In this slide, we can see that there are eosinophilic structures in the middle of gland, which is seen in early stages of prostate cancer. These are not seen in higher stages. These are seen in early stages of prostate cancer. And here we can see there is one gland, another gland, another gland. So this is back to back gland commonly seen in prostate cancer. Then those are the classification and characteristics seen on slides. So now we will move to the grading of the prostate gland. So there's very popularly pattern scale known as Gleason's pattern scale, in which we classify the glands in the pattern in 5 classes. So in very first class, we can see there are small uniform glands, small and very uniform appearance. So these are well differentiated cells, and the scale goes from well differentiated to the most poorly differentiated. In first scale there are those. In second scale we can see the glandular structure is kind of getting lost here. So there are no uniform glands, and we can see more spaces in between the glands. In third scale there are infiltrating of cells. Here we can see at the margins, infiltrating cells from the margins. So this is third, moderately differentiated. In fourth we can see irregular masses of neoplastic cells. Here we can see those. And in the last, in the most poorly differentiated, we can see there are seeds. Here there are seeds of cells. This is the characteristics for prostate cancer, seeds of cells, and this is seen in very highly progressed cells. And Gleason score, how it, there are five groups we already have discussed. And how we do Gleason scoring is we take two scores. These two scores means we see one part of the slide and give it a score, then we see another one part of the same slide and we give it a score, and then we add those score and add them, and we get a total score. So Gleason score ranges from 2 to 10. So 6 means this comes in first group, and 10 comes in fifth. So this is Gleason pattern scale. Next, interpretation of the Gleason score. From 2 to 6, this is well differentiated with excellent prognosis. The 7 is moderately differentiated, and from 8 to 10, this score means those are poorly undifferentiated. Okay. Staging of the prostate cancer, which is TNM staging. So T1 is clinically inapparent, and then T1A is when the 5% of the tissue is 5% or less than 5% of the resected tissue, the tissue we have taken from the cancer, is involved. That is T1A. T1C is carcinoma present on needle biopsy. So all of the tissue is all of the tissue is involved. That is T1C. T2 means the malignancy is palpable or visible. So that is T2. T1A, sorry, T2A involves more than less than 5 and of one lobe, less than 5% or 5% of one lobe. And T2B means more than 5% of one lobe, but unilateral, not in both lobes. T2C is that involves both lobes. T3 is local prostatic extension. So there is extended the tumor mass. T4, there is invasion of to the other organs like bladder, neck, rectum, external sphincter, and those are involved in T4. This is the most aggressive ones. And there is N. N means N represents the number of lymph nodes that it involved. Those are involved. So N0 means no lymph node involved. N1 means it involves the regional lymph nodes. And M refers to the distance of metastasis. So M1 is distant metastasis present, and M0 means there's no distant metastasis. So this is the staging of the prostate cancer. Then we will move to the diagnosis. Diagnosis involves this test: PSA, prostate specific antigen testing. So the level more than 4 suggests there is prostate. It is not the hallmark, but it suggests there is malignancy when it is more than 4. However, we need to consider some other factors, such as there is age specific prostate, free prostate, sorry, age specific PSA, pre PSA, PSA density, and so many things, other things that we need to consider. We can't just look at these 4 and 4 or more than 4 and we will call this is a prostate cancer. No, we need to consider all these things. So this is the one. Then we have got digital rectal examination. The third one is tumor health index or 4K score test. Then we have transrectal biopsy. Then there is random 12 core biopsy. In this we take 12 we take biopsy from 12 from the biopsy tissue. We look at the mass of 12 places randomly, and then we will look inside the microscope. Then we have got multiparametric MRI fusion biopsy, and PCA prostate cancer 3 gene testing. So these are the diagnostic methods for prostate cancer. DRE PSA testing, ultrasound, random 12 core biopsy, MRI fusion biopsy, and then there is PCA 3 gene testing. Next we will move to the treatment of the prostate cancer. This involves active surveillance. By active surveillance we means there is a testing of PSA level, digital rectal examination we will check, and we take biopsy regularly. So these 3 are done regularly, and we will actively monitor the progression of the tumor. Then there is surgery. If the tumor is advanced, then we have to surgically remove this. There are radiation therapy, and others include cryotherapy, chemotherapy, biological therapy, hormone therapy, and high intensity focused ultrasound. So these are the treatment.